Thank you for inviting me to speak at the SFCCC Survivorship Symposium in 2025. My name is Dr. Sam Richter. I work in the Department of Radiation Oncology at the Lynn Cancer Institute, and today I'll be talking to you about the radiation long-term side effects. I have no disclosures or conflicts of interest to report, other than I am a radiation oncologist and I like what I do. So for the purposes of today's talk, we're going to go through a little bit about radiation therapy, review late side effects of treatment by organ or disease site, as well as review strategies and technologies to minimize late side effects. Radiation therapy is often thought of as a scary treatment and something to be avoided, but harnessing the power of radiotherapy and utilizing it safely and conformally can allow for significant therapeutic benefits. Like I tell all my patients, there's no free lunch. Any doctor who tells you there's a 100% chance of cure with 0% risk of side effects is probably not telling you the whole story. It's important to note that side effects of therapy, which we'll talk about, are possible, but are not necessarily expected with treatment or experienced by all patients. Every patient is different and unique and may have inherent sensitivities to treatment. As a radiation oncologist, I'm often tasked with balancing the need to treat the cancer now, at the present time, but also taking into consideration the risks of treatment, both during therapy as well as in the future. Today we'll talk about some of those future risks. Those are the late and potential side effects of radiation treatment. So, what is radiation therapy and how does it work? Radiation therapy works by damaging the DNA of cells and destroying their ability to reproduce, that is, the cancer cells. Both normal cells and cancer cells can both be affected by radiation, but cancer cells generally have impaired ability to repair this damage. This leads to cell death. All tissues have a tolerance level or maximum dose beyond which irreparable damage might occur in either the delayed or more chronic late side effect situation. What are the functions of radiation therapy? Why do we administer it? Why do we offer it to patients? Well, the two main functions are really to cure cancer, to destroy or ablate tumors that haven't spread, to kill any residual microscopic disease left after surgery or even chemotherapy. And in many cases, it's simply just to palliate symptoms, to shrink tumors that might be affecting your quality of life, such as a lung tumor which is causing shortness of breath or blocking the airway, or to alleviate pain or other neurologic symptoms by reducing the size of the tumor and preventing it from getting bigger, both in the case of, let's say, bone metastases, which are painful, but also in the case which you see on the right of spinal cord compression, in which a tumor is growing within the spinal column and is infecting the spinal cord, which can lead to other downstream effects. Going through radiation therapy effects, it's important to know what are early effects and what are late effects. Early effects result from the death of a large number of cells and occur within the first few days or weeks of treatment due to cells with rapid turnover feeling the effects of treatment. These effects can be rapidly repaired because of the proliferation or the reproductive integrity of those cells and can be completely reversible. Early effects tend to happen both during the radiation period as you're getting treatment, but also up to 3 months thereafter. Late effects happen greater than 3 months to even years after radiation therapy. They're often delayed. They're predominantly seen in slowly proliferating or slowly reproducing tissues, such as the lung, the kidneys, the heart, liver, or even the central nervous system. Late effects can improve, but may never be completely repaired. Late effects are generally dependent on which tissue or part of the body seeing the treatment, what volume of tissue is being irradiated, the dose of the radiation, as well as any other treatments which might be given alongside of it. The line between an acute effect and a late effect is often very blurry. Early late effects that are severe can lead to consequential late effects if not properly addressed. So going through side effects by organ system, I'd like to walk us through some of the skin late effects of radiation therapy, some late effects as they pertain to the heart, the lungs, the GI tract, and then also the brain. So when we think about the skin, what are some of the late effects of radiation therapy that we might see in the skin? What we see here is the potential for fibrosis, telangiectasia, or squiggly little blood vessels, which may happen at the surface of the skin. We can sometimes see what's called radiation recall, where the administration of radiation in the past is brought out by other drug therapy in the future. We can see some shrinkage of tissues. We can see necrosis or dead debris of tissues on the inside, as well as even secondary skin cancer. And what you see here is a chart depicting a Caucasian versus an African American patient who's received some breast radiation therapy. And what you see are the different stages of radiation dermatitis. This is commonly seen with patients with skin cancer. Obviously, panels D and H, all the way on the right, are very, very rare. More commonly during a course of treatment, we might see what's happening in panels A and E. A and E, where we might see a more common redness of the skin or a slight darkening or hyperpigmentation of the skin. But for the most part, these effects, with proper care, ointments, moisturizers, these tend to get better over time. Fibrosis is also commonly seen in breast cancer patients. That is a tightening or irritation of the skin. The risk is particularly low with the use of skin-sparing radiation equipment and techniques. And what you can see as a result of fibrosis is skin retraction and induration. You can lose elasticity. You can have breast shrinkage. Joint spaces, such as the shoulder, let's say, could have some impaired mobility, and there can even be some swelling of that tissue. What you see on the right is an example of a woman who's received prior whole breast radiation therapy, perhaps in a different era, maybe decades ago, and you can see some asymmetry and some shrinkage of breast tissue since she had her whole breast treated. Again, these are uncommon, but this can happen. How do we prevent fibrosis? Well, if we spare the skin, if we spare some of the underlying subcutaneous tissues, we might get a more homogeneous or even distribution of radiation therapy dose, such that we won't see significant fibrosis. Perhaps changing the field of radiation therapy from a whole breast treatment to perhaps a partial breast treatment can limit the exposure of healthy tissue to radiation, particularly in the case of breast cancer. Also, some vitamins, like vitamin E, for instance, can be used to help prevent or even treat the cases of significant fibrosis. What you see here on the right is an example of radiation therapy treatment plans. On the top, we have an example of a woman with a breast implant receiving radiation therapy to her tissue that sits in front of the implant, her residual breast tissue after undergoing breast conservation. What you see here is not only a skin-sparing radiation technique, but an implant-sparing radiation technique, such that we're avoiding capsular contracture or maybe deformity as it relates to the implant as part of this woman's breast cancer treatment. In the bottom panel, we see a case of not whole breast radiation, but rather partial breast radiation, in which a patient is being treated just to this upper outer aspect of the breast instead of treating the entirety of the breast. These techniques may help us prevent fibrosis by sparing a lot of the otherwise healthy breast tissue. What you see are these colored lines. These colored lines represent radiation dose. And as you can see, the farther away from the target we get, there really aren't these colored lines. And this obviously is a part of the breast tissue here and here, which is being spared from the radiation therapy. Another example of a late effective treatment is something called a radiation recall reaction, which can present itself as a rash, perhaps dry, perhaps itchy, or even swollen, in an area where someone received previous radiation in the past. Generally, some chemotherapies and other drug therapies may bring it out. Here's an example of a gentleman who was treated to the back and had radiation therapy to the spine. He went on to get chemotherapy, and for some reason, his skin reacted in such a way that it showed the exact field or the exact area of where radiation was once penetrating in the past. Generally, this resolves after withdrawing some of the medication and is managed topically with moisturizers and ointments, such that we would manage radiation dermatitis. Skincare is very important when it comes to radiation therapy, whether it's patients getting breast radiotherapy, which obviously a lot of skin is exposed to, or perhaps even head and neck cancer, or the neck or the face may be seeing some radiation. There are a number of different ointments and creams that are on the market that can be used to help address any skin toxicity, from things like over-the-counter Aquaphor to more prescription burn ointment like something called Silvadene. Even people have gotten very creative with ointments, Utterly Smooth being one of them, which you can buy online. People love calendula, which is the main ingredient of a lot of other mixtures and ointments, but skincare is super important when it comes time for managing acute and both late effects of radiation treatment. And when we think about the heart, any component of the heart can be impacted by radiation therapy. Late effects tend to manifest either as chronic pericardial disease, coronary artery disease, cardiomyopathy, or valvular disease, or even some conduction abnormalities, such as disrupting maybe the electric circuitry of the heart. Again, all very, very rare. Treatment-related risk factors regarding cardiac toxicity relate to radiation dose, the dose per treatment, the volume of the heart actually seeing the radiation, and any simultaneous administration of drugs, such as some HER2 agents or even chemotherapies, which can also affect the heart. Patient-related risk factors include a patient at a younger age, females, other people at risk for coronary artery disease, such as those who are smokers with obesity or even high blood pressure. We know from studies, specifically Darby et al., that the exposure of the heart to radiation increases the rate of ischemic heart disease. The increase is proportional to the mean dose of radiation to the heart, and women with pre-existing factors, such that I just mentioned, may have a greater increased absolute risk of heart disease. So the name of the game is, how do we better decrease the dose to the heart as much as possible? How do we spare the heart from radiation therapy? It was estimated that 7.4% increase in rate of coronary artery events for every 1 gray of radiation touching the heart. Limit the dose of the heart, we limit the late effects of radiation on the heart. The ways we minimize dose to the heart, we have a couple different techniques, specifically in the realm of breast radiation therapy. We have something called deep inspiratory breath hold, prone positioning, partial breast treatment, which we alluded to earlier, as well as proton therapy. Deep inspiratory breath hold, which we commonly employ for patients with left-sided breast cancer. Patients are coached or instructed on their breathing. They have video-assisted goggles or even lights in the treatment room, which gives them feedback as to when they should be holding their breath during treatment. Only when their lungs and their breathing is in the correct optimal position, only when their chest is in the right position, does the actual radiation therapy treatment beam get delivered. By pulling the diaphragm down, right, if you inflate your lungs with air, you're expanding your diaphragm, you're increasing the total volume of air in the lungs and increasing the volume of lung tissue, and also potentially pulling the heart down and out of the way of the radiation beam. And what you can see here is, if I drew a line along the back side of what a radiation beam would look like, covering this breast tissue, if somebody holds their breath for just a few seconds, cyclically, in a cycle format throughout the course of their treatment, this heart gets out of the way and the lungs expand such that less lung tissue is getting the radiation therapy. Here's an example of also sparing the heart and lungs by putting a patient in the prone position on their belly, laying on essentially a massage board, letting gravity pull the breast farther away from the heart as well as the lungs. What you see here are a diagram of the radiation fields coming in, glancing over the chest. In the supine, or on your back position, the front part of the heart is seeing more of radiation. Whereas if you have someone maybe on their belly, when you have to give them whole breast radiation, the heart is less exposed to treatment. Here's an example of what somebody might look like when they're positioned in the prone position. This breast board here has a cutout, almost like a massage board for your face, except this time the breast is falling through the table, and in doing so is stretched and pulled farther away from the internal organs. This has great efficacy not only in treating the breast, but also in sparing the heart and lungs, as we just mentioned. Another way to spare the heart and lungs, but also healthy breast tissue, like we spoke about before, is giving what's called partial breast radiation. What you see here is an example of our CyberKnife system, a treatment platform in which sometimes we give partial breast radiation. But here, more importantly, is an example of an isodose distribution, or essentially what somebody's radiation plan would look like in 3 different positions, sending radiation in from different angles to really sculpt the dose just in the vicinity of where their prior cancer was removed. For carefully selected women with very favorable features, and in this woman's case, in close proximity to her implant, which we're also trying to avoid, radiation therapy can be delivered in just 5 treatment sessions, once a day, maybe a half hour a day, which is quite different than many years ago when we used to give treatment in as many as 7 or even 6 weeks of radiation therapy. The efficacy of this treatment and giving it in 5 sessions seems to be just as good as a long course of treatment over multiple weeks. And in terms of cosmesis, in terms of patient satisfaction and convenience, we're sparing a lot of healthy tissue and giving patients, we think, perhaps superior care. When we think of the gastrointestinal system, with respect to the bowel and rectum, patients with late effects from treatment can see chronic diarrhea, malabsorption, obstruction, or even ulceration and bleeding within the GI system. What you see here, again, are different radiation therapy treatment plans for patients with prostate cancer. This is an example of 3D conformal radiation, in which you're getting beams coming at the patient from maybe just 4 different angles. Here's an example of a crude IMRT plan. Here's an example of a helical spinning radiation therapy treatment plan trying to focus the treatment just on this prostate. Here's an example of pencil beam scanning, proton therapy, and intensity modulated proton treatment. Here, an example of brachytherapy. And what you see here, because of where the rectum is in proximity to the prostate, the name of the game with prostate radiation is to fit in treatment to the prostate but spare the bladder and the rectum. In all these scenarios, regardless of the flavor of radiation or the technique, the rectum is going to get some radiation therapy dose. So how do we protect the rectum? Well, obviously we want to choose treatment planning that is maybe more sophisticated than this cruder plan, and generally we fall into this category here, in which patients either have intensity modulated radiation therapy or proton therapy in some select cases for their prostate cancer treatment. So just to go over the prostate, is a walnut-sized gland between the bladder and the rectum. A company had come up with an idea: what if we could put a naturally absorbable gel between the prostate and the rectum to better create space and a buffer between the high doses of the radiation therapy and the rectal wall, which sits immediately behind the prostate, which incidentally always gets a little bit of radiation therapy when prostate cancer is delivered. Not only does this allow for rectal sparing treatment, but allows us to dose escalate and increase doses to the prostate while sparing the rectum, perhaps allowing us to achieve even better control of prostate cancer and creating more of a separation and a buffer with the rectum. What you see on the bottom panel is an example of a prostate MRI. What you see here is a prostate gland sitting right in front of the rectum. Here we have the gel that's inserted, creating space between the rectum and the prostate. Looked at in a different view from the side, we see that the prostate is now pushed farther away from the rectum. It's not mandatory for all patients with prostate cancer to receive this gel placement, but it is something which should be spoken about by clinicians to their patients, letting them know that they have the choice potentially to do this and have this put in one time ahead of their appointment. Another example of a way to be more conformal and precise in treatment delivery is to use different machines and different technologies, such as the Meridian, which is an MRI-guided radiation therapy machine. I'm happy to report that LCI has added another weapon to the arsenal in our fight against cancer. What we see here is our Meridian machine. It's in our Delray Beach office. And as compared to other techniques, the MR-Linac has the unique potential to be able to ensure that the treatment you're intending to deliver is what's actually being delivered in real time. This machine also allows for adaptive planning based on tumor position and location. Let's say somebody's more gassy one day versus the other, or for whatever reason their bladder or another organ is more full or less full on a daily basis. What this does, and by allowing us to adapt and change the treatment plan in real time, allows us to reduce dose to normal tissues such as, let's say, healthy lung, bowel, bladder, rectum, and things like this. This is an example of a recently treated patient in which we had to treat her lung cancer sitting just behind the diaphragm, tucked on the bottom of her lung. And as you can imagine, anytime she breathed, her lung and the tumor would move. And so what we want to make sure, and by making sure the treatment target is in the same position accurately every day, we thereby spare more healthy organs in the neighborhood, such as her liver and her lungs. This woman was treated in just 5 treatment sessions, and what you can see just several months after treatment, her tumor, which was once of this size, is now decreased to this. So still on its way to shrinking and going away, but clearly an excellent response to treatment just 2 months after. Another example of the meridian being used to treat, let's say, a liver tumor, which may be in close proximity to the stomach or to the intestine or bowel. Trying to give ablative or conformal high-dose treatments to the liver can often be challenging due to proximity to the bowel. Last thing we want is a perforation or a fistula or GI upsetness, nausea, vomiting, things like this. So by being more conformal and precise, perhaps using the meridian, we've been able to do so. I won't spend too much time on the lungs, but receiving lung radiotherapy can result in radiation-induced lung injury. The one common side effect that we see is something called radiation pneumonitis. It typically happens 3 to 12 weeks after receiving treatment. There can be different phases to that quote-unquote radiation pneumonia, but the one side effect that we hope to avoid by being more conformal in the earlier stages of radiation therapy delivery is to avoid fibrosis, which generally can set in as early as 6 months and can progress over years. What affects radiation in lung injury? It's the volume of lung being treated, the doses, the frequencies, the techniques, what's being given alongside of it, whether in any immunotherapy or other chemotherapies, both before or thereafter. And then there are things that patients can control: smoking, COPD, and their baseline interstitial lung disease. Radiation-induced pulmonary fibrosis generally happens late, and just to distill this slide, it's really prevention. We want to prevent this from happening by limiting the dose and the volume of radiation, lung, being exposed to the radiation therapy. This is an example of a patient who received a 5-fraction or 5-day treatment course of radiation therapy to a large squamous cell carcinoma of the lung, which you can see here in this left panel. This is an example of her treatment. You can see the PET scan showing that there was this glowing large lesion within her right lung. Immediately thereafter treatment, approximately several months after, we can see that this lesion, it was essentially ablated, flattened, if you will, in which there's no more residual disease. This is an example using SBRT, or stereotactic body radiation therapy, in lieu of surgery or in patients who can't have surgery to get rid of tumors. What you see is by sending in the beams of radiation from different angles, all converging on this area, we're able to get a very tight and conformal treatment plan. As far as the brain's concerned, what are the late effects of radiation therapy on the central nervous system? We can see radiation necrosis, neurocognitive decline or changes in memory, cataracts. We can see stroke-like symptoms. We can see changes to vision. We can see changes to hearing. We can see changes in hormonal levels as it relates to, let's say, the pituitary gland, and even secondary cancers. One of the late side effects of radiation therapy in the brain that we look out for is something as it pertains to memory or neurocognition, which can be impacted by whole brain radiation, as well as even partial brain radiation. There are neuroregenerative stem cells within the hippocampus, which are very sensitive to radiation, but which are also very important for our thinking, for our cognition. On the right is an example of a whole brain radiation therapy treatment in a small cell lung cancer patient who had innumerable small little brain mets, who got a course of whole brain treatment. And while that got rid of all these spots, while it got rid of all the cancer, which you can see here, it can result in lasting and potentially permanent neurocognitive decline. So how do we manage this? Well, instead of giving just one beam of radiation from one side of the head and one from the other and treating it through and through, we've gotten more sophisticated in our treatment techniques. These days we do what's called hippocampal sparing radiation, in which we avoid those memory centers, the hippocampus. And what you can see here is radiation being sculpted out of those areas in an effort to better preserve memory and neurocognitive function. There have been multiple clinical trials looking at this, and it does seem to have no difference in terms of the control of the cancer, but better outcomes 6 months after the radiation therapy is given in terms of the patient's ability to recall, to think, and to function. As far as medical therapy, when it comes times for neurocognitive preservation, treatments individualized, supportive therapy such as Provigil or even Ritalin to help patients energy or activity stimulating the brain. Things like memantine or Namenda, which is an NMDA antagonist, can be used. It's been studied in clinical trials to help reduce the chance of any neurocognitive toxicity and improves outcomes 6 months down the line. Like we had spoken about before, our CyberKnife machine allows us to deliver something called stereotactic radiosurgery, or SRS. Instead of going in and doing surgery on every one of these little cancerous spots in the brain, one way to avoid all the toxicity of treating the whole brain is to stop treating the whole brain. What if we just treat the individual spots with more highly conformal, high-dose treatments? And for patients with metastatic lesions in the brain that are more limited in number, sparing healthy tissue and trying to ablate the disease to higher doses, we would generally use a technique of stereotactic radiosurgery. Sometimes that's treatment given in just a single treatment, sometimes as many as 5 sessions, but definitely another tool in the toolbox, helping us be that much more conformal with our therapy. Again, another example of a larger, more cystic lesion in the base of the brain. Again, all these little beamlets of radiation coming in, all converging on this area, and what you see here is almost a complete response with no residual disease within this part of the brain. Another late effect of radiation therapy of the brain, which can be symptomatic or asymptomatic, is radiation necrosis. Symptoms can be related to some swelling in the brain, can be related to where in the brain it's located, what the dose of radiation therapy given was. Generally, imaging such as MRI with perfusion can help give us a map of cerebral blood volume and may help us differentiate between necrosis or tumor. Things like steroids, laser interstitial thermal therapy, or even surgical resection can be used to manage radionecrosis in the brain. Drugs like bevacizumab or Avastin can be used. But again, like you've heard for other organ sites, prevention is the best modality and the best tool for actually avoiding neurocognitive toxicity and radionecrosis in the brain. We want to be able to avoid this, not necessarily have to manage it thereafter. I get a lot of questions about proton therapy these days. Proton radiation is something which reduces the dose to normal tissues by allowing for more precise dose delivery because of the unique physical properties of a heavy particle, which is what a proton particle is. Protons penetrate tissue to different depths depending on their energy, and then deposit that energy in the tissue in a sharp peak. This is known as a Bragg peak. And what you see here are X-rays coming through, continuing to fade off as they get deeper within tissue, whereas with a proton, protons travel, they peak, and then immediately give off their energy so that there's less of a trail, less of a tail. What you do is within a tumor, you spread out this Bragg peak such that we're giving radiation over the entire size or the entire length of a tumor. This rapid dose fall off at the end of its range allows for decreasing dose to adjacent normal tissue. For many patients whose tumors are located in or near critical structures, proton therapy represents a unique opportunity to reduce late effects of therapy. It's an amazing weapon in the fight against cancer, and we're privileged to be able to soon have this at the Lynn Cancer Institute. But it's important to note that proton therapy isn't necessarily the right choice for every single patient. While promising, the data on its use in all disease sites is still emerging, and multiple clinical trials are currently underway, for many sites, such as breast cancer, lung cancer. I would say that proton therapy these days is more established in the cases of reirradiation, in the cases of brain tumors that are in very delicate locations, maybe more anteriorly or towards the front of the brain, near nerves, in cases where we're nearby the spinal cord, and particularly in patients who are young, in the pediatric population, where the integral dose or that low dose bath of radiation as the beam is traveling, we want that to be as low as possible in somebody who's still growing. This is a map of all the proton facilities by year of operation and establishment as of last year. And as you can see, proton therapy is rare, and it's a unique technology that we're very lucky to be bringing to South Florida at the Lynn Cancer Institute. You can see the little dots scattered about really show where these centers are. And of course, we're fortunate to be able to have one just in our backyard at the Lynn Cancer Institute. Here are some renderings of the proton facility that's up and coming. It will look exactly like this. It's starting to look exactly like this, and it's really just another institute that we've added on to our existing center. And what this will mean for our patients is that they're going to have all their cancer care, whether it's proton or photon, whether it's with medical oncology on the second floor, or the surgeons on the third floor, all under one roof in an absolutely beautiful and state-of-the-art facility. Just to talk about it a bit, how do we decide who to treat? When to treat them? What treatment technique do we use? Decisions about cancer management are best made in a multidisciplinary clinic and tumor board. The management of cancer is a team sport. Each patient's treatment strategy needs to be individualized. At LCI, our team of surgeons, radiation oncologists, medical oncologists, pathologists, radiologists, social workers, nutritionists, geneticists, and research coordinators all get together every week for individual conferences for every single disease site. We have lung, we have brain, we have head and neck, prostate, breast. We have tumor boards for virtually every disease site. And we get together and discuss the individual points about each patient. We have a standing clinic where patients are actually seen sometimes before these tumor boards, where they actually get a chance to meet in almost like a round-robin fashion with each of the different specialists. This saves time. This is the pinnacle of care coordination because they're getting maybe 3 or 4 or even 5 opinions all at once with just one morning invested being at the center. I think this is what sets our program apart from other centers in the area and maybe even the country. I believe that cancer care needs to be a team sport. It has to be done in this fashion, and I think you get your best results when it is. In conclusion, the late side effects of radiation appear after a delay of months or years after treatment. Late side effects depend on which tissue or part of the body is being treated, whether the skin, the brain, the breast with respect to the heart, what amount of tissue is being irradiated. Is it partial breast? Is it whole breast? Is it part of the brain? Is it the entire brain? And the dose of the radiation administered. It also makes a difference as to how the treatment's being delivered. What is that treatment technique? With modern contemporary radiation therapy techniques, these late effects, some of which we've explored today, are really, really rare. If other treatments are being given, such as chemotherapy or immunotherapy, that may have some bearing on whether any of these late effects will actually manifest themselves. Other things to look at are individual patient risk factors, things that you in the audience or things that patients who are getting cancer treatment can control, whether it's smoking, diet, exercise. These are things that patients who are receiving radiotherapy may have some impact on. At LCI, we utilize the latest technologies, techniques, and protocols to individualize treatment so that we can minimize the late effects of therapy. And just to show you, we have a number of different supportive services. We have an amazing social work team. We have virtually support groups and wellness programs for every disease site, for every type of patient, and even the caregivers and families of the cancer patients. Here's just an example of a smattering of programs and flyers that we get on almost a daily basis, showing how active the center is in keeping patients informed and families informed and providing services to make sure that their cancer journey is as tolerable and pleasant as it can be as they're going through this tough time in their life. And with that, I'll conclude. Thank you for your attention.